So we welcome everyone to this session of Sign Out with the Professor. We're going to talk about cases in the pancreatic pathology and some tools that you may find useful as we consider the pancreatic neoplasms that we will talk about. I sort of started with the cystic neoplasms because I think those oftentimes form one of the more challenging differentials. So I don't know about you, but this looks a little bit like a cat to me, but the tissue section, but this is a piece of pancreas. And as you can see, it has multiple cystic spaces and some cellular tissue as well as the surrounding vessels, and maybe here up the bile duct up here at the top with surrounding nerves, or maybe that's just more pancreas there as well. But as we look at this, there are two features that I think should stand out to us. One is the cystic spaces. The nature of the epithelium lining these cystic spaces appears to be mucinous. You can see there's quite a degree of pale bluish purple cytoplasm that is characteristic of mucinous tissue. And there's a degree of epithelial atypia that we can see in this case. There's a little bit of nuclear enlargement and sort of crowding. So this is a pattern of low-grade dysplasia in the pancreas. It's not high-grade dysplasia or carcinoma. And then the stroma around these cystic structures is relatively collagenous and so forth. There are a few areas where we get some other features here, a little bit of hemorrhage and hemosiderin deposition. And then we have these smaller glandular areas here that look a little bit lobular. Notice the sort of rounded configuration of these. And these probably represent compressed atrophic pancreatic acini that have just lost all the acinar epithelium and have only a bare amount of remaining ductal type epithelium. Now, the other feature here is that we see that we're kind of near the liver here. So there's a little bit of cirrhotic liver tissue here. So this could be something that's happening in the biliary ducts of the liver. And that's an important thing to recognize because many pancreatic cystic neoplasms can also present in the biliary tree as well. So based on that clue, even if you didn't know, the specifics, this presence of liver tissue would lead you to suspect that you're either in the gallbladder or in the biliary tree. And based on the size of vessels here, I think you would assume that you're in the biliary tree because you've got liver kind of all around here. So this is a tumor with mucinous epithelium. It's got some degree of papillarity, a low-grade dysplasia. You see some of this little papillary change here. And it has a fibrotic stroma with some areas of reaction. So this would fit into the category of intraductal papillary mucinous neoplasm, here occurring, as we would say, in the biliary tree, in the hilus of the liver. Now, anytime you make a diagnosis of IPMN, or intraductal papillary mucinous neoplasm, you need to look very carefully for evidence of invasion. And invasion in this situation is defined as not this kind of pushing and expanding cystic growth, but as something that shows evidence of stromal infiltration. And that can be defined in the presence of perineural invasion So we'd want to look around the various nerves. And the other feature that can be somewhat useful is the presence of incomplete glands. So this is a structure here, which looks a little bit like it might be an incomplete gland. We have a space that's not completely lined. So this could be an invasive gland, or it could be this is just an artifact. Usually with the invasive glands and that are incomplete in this pattern, you will also have an inflammatory reaction or a tumor diathesis, we would say, that extends into the lumen. And that is not something we see here. So this is probably an artifactual change rather than a true neoplastic change. So glands where they shouldn't be, immediately adjacent to nerves, or juxtaposed to large vessels, those are the things you would look for neoplasia. I didn't see those here, and so I think that this qualifies as an intraductal papillary mucinous neoplasm, in this case occurring in the hilus of the liver. Now that's obviously not the most frequent location, but it's certainly one where you do need to be aware that it can occur in that location. So we'll go on to the next case, and some of these are somewhat related. As you can see here, this is also has a very papillary architecture, large cystic spaces, and probably you can also appreciate that it has mucinous epithelium. So as we look at these lesions and the cells here, we can see again we have abundant cytoplasm. The nuclei are mostly at the base of the cell, although there is a little bit of stratification and crowding here. So maybe the dysplasia is a little bit higher than in that last case. Again, we have a rather collagenous fibrotic stroma. That's helpful. And we can see a few budding areas off of the side of here, but we don't see evident invasion right away. So here's another question. Is this an incomplete gland? Again, we don't see the epithelium lining all the way around, but it is sort of fragmented. So this could be a partially autolytic change. And we don't see the intraluminal diathesis. What we do notice here, however, is that the dysplasia is a little bit higher grade. See how the nuclei essentially completely fills the cytoplasm, and you can compare this cell group here to the lower grade dysplasia over here and see a clear difference. So originally, these lesions that are cystic in the pancreas were, well, I should say originally, but several efforts have been made to determine when surgery needs to be performed. There are two main categories of cystic mucinous neoplasms or intraductal papillary mucinous neoplasms in the pancreas, the so-called side branch type, which typically are relatively small, don't tend to progress, maybe multiple, and then the main duct type, which involve the entire main duct. And various criteria were proposed to determine when it was worth the risk of doing surgery on these lesions. Size was one criterion. When things were over 3 centimeters, the Nagoya criteria specified that probably should be excised. When there was a mass or a solid component, that was a feature. Or when you had evidence of higher grade dysplasia on cytology. So getting a sample from a cystic lesion like this would give you higher grade cytology and therefore would lead to surgery. I think you could call this high-grade dysplasia in this location. Well, that also should then lead us to search more carefully for possible invasion. Again, we have this sort of hemorrhagic component here, and hemosiderin deposition. We'll go up and look around just a little bit and see what else that we can see. So here's a feature out here that looks a little concerning, but this doesn't look like the type of stromal response to tumor. I wonder if this is an artifact rather than true invasive tumor here. Now, adjacent to here, we see another feature that's very common in these lesions, and that's the presence of residual islet cells. The islets are not destroyed when you get ductal obstruction or damage, and so they will oftentimes persist and can be somewhat deceptive at times. Now here, however, we begin to see some features that maybe raise a little bit more concern for invasion. So notice this little structure here. It sort of extends out into the stroma a little bit. And here, we're starting to see what I was calling or describing for you earlier, the tumor diathesis. This is dead cells, necrotic debris, and associated inflammatory cells. And then over here, you can see there's what probably are epithelial cell nests out in the stroma. So this likely represents a tumor diathesis in an invasive component in this lesion. It's not very extensive, obviously just very focal here, but we'd want to continue to look. And especially where we're seeing the diathesis and high-grade dysplasia, we should be very concerned about this possibility and go to thoroughly sample and examine these lesions. Obviously, if you were to see a tumor out here in this vascular bundle area, that would be very concerning also as evidence of invasion. I think here's one other feature here that is not, whoops, wrong direction, is not diagnostic of invasive carcinoma, but is certainly very concerning. You see here this pool of acellular mucin, sort of extravasated mucin that's outside of the cystic space. This also should lead you to perhaps do levels to look for maybe cells in this tissue that look malignant, because a pool of mucin like this outside of the ductal structure would be concerning for possible invasive mucinous carcinoma as well. Now, there's another feature here that is a sort of a little bit concerning here. As you look at these nerves, these look a little bit concerning. They have this cuff of cells around them. And so if these were epithelial cells, this would be, perineural invasion, but they're more spindle shaped. And so this is a perineural reaction in this area. We also get a little bit of this sort of reactive change in this little lymphoid aggregate, where there's a little bit of mucin here surrounding this maybe germinal center. So again, some other soft features to suggest that the tumor is provoking some response in the stroma that is a little bit worrisome for invasion. So I think those were the main points I wanted to share from this slide. The evidence of very early invasion, the tumor diathesis, the evidence of intraepithelial high-grade dysplasia, prompting more rigorous search for tumor. And then the perineural reaction. All right, well, let's go on to an additional case here, a little bit more clear cut. Obviously here we have a lot of mucin. We have some lymph node here, and maybe some evidence of extension into the lymph node from this pancreatic tumor. We'll focus first on this piece and then come look at the one here on the right. So here we see, again, a complex epithelial pattern with a lot of mucin. And notice here we have almost a little bit of more intestinal type of change, a few goblet type cells. And that is an indication, a reminder that these papillary intracystic neoplasms can have a variety of epithelial phenotypes. They can be oncocytic, they can be pure mucinous, they can be a little bit more intestinal. But here we see there's some dysplasia, and we're getting near solid growth here with this more complex architecture. A little bit more coarse chromatin, but not really anaplastic per se. But we see we're also getting some stromal fibrin deposition with mucin. Here's again extravasated mucin with this fibrin deposition, and then more of it over here. So it's essentially forming a sort of a pseudomyxoma type of lesion as we move into the tissue. And then we see that really there's no true boundary with the fibrous stroma. There's no epithelial lining here. So this would be a mucinous carcinoma coming out of probably an intraductal papillary mucinous neoplasm. Now these tumors are considered a ductal phenotype, and therefore the pattern of mucins that will be displayed is usually that of a pancreatic ductal adenocarcinoma. Now, the other piece of tissue here also had lymph node tissue in it. And here we can see this tissue extending into the lymph node, which is sort of surrounding it on three sides. So this would constitute direct extension into a lymph node. And even though we don't see very many tumor cells here, I think a rigorous search would ultimately disclose that here we see, tumor cells here, that this is tumor-related mucin, and therefore with viable tumor cells in the mucin lakes, this would constitute involvement by the lymph node. So making it at least an N1 type of stage. So that's kind of the spectrum on these intraductal papillary mucinous neoplasms and the development of invasive type ductal adenocarcinoma. Let's go on to another case. Here's another example. And just to give you a feel for the spectrum of lesions that we can see. So here we're at the margin of the pancreas, and we can see there's extension out into this peripancreatic space out here, involvement here and here. So let's look first at the grade of dysplasia that we have. We see that there's stratification. There's still some preservation of the basal nuclei, but they're really quite stratified. And in some areas, they're getting a little bit of less mucin and more towards the surface of the epithelial cell. So if we were grading this as a pancreatic intraepithelial neoplasia, this would be at least a grade 2 and probably in some areas would approach a grade 3. So it's getting close to intraepithelial carcinoma. Here's the higher grade pattern here. With some solid growth here, and you can see here that we've lost the mucin here. So this is a high-grade dysplasia or intraepithelial carcinoma, essentially, in this intraductal neoplasm. So then our job is to verify whether or not there is invasion, and many of these cases can be quite challenging to determine the presence of invasion because it can be subtle, as that earlier case showed. It can be very, very subtle changes. The inflammation may or may not give you a clue. But here we see a nice evidence of an incomplete gland. This is perhaps as classic a case of an incomplete gland as we might see today. So epithelial lining, cystic space, and then boop, all of a sudden the epithelium stops. No further lining epithelium. This is an incomplete gland and is a very strong criteria in the right setting for invasive neoplasia. Now, it illustrates that sometimes these glands with incomplete lining, incomplete glands can be large, and sometimes they can be small. We'll come up here and come out here again. Now notice here that we have some residual islets around this nodule here. So this is probably not extrapancreatic extension of tumor. This is probably extension into a side branch where you've had a pre-existing lobule that is now atrophic with just a few residual islets remaining. Still, we would want to examine these nests quite carefully to make sure that they were not epithelial malignancy, but were in fact neuroendocrine cells. And if necessary, you might need to do a marker like synaptophysin or something of that sort to determine, because as you can see, sometimes these little nests can get a central lumen-like space in some of them. But in fact, these are all residual neuroendocrine cells. This is not evidence of an invasive carcinoma component, at least from this area. The incomplete gland we had earlier would suffice, however. Again, more residual neuroendocrine cells, and so forth that will remain after the pancreas becomes, the acinar epithelium becomes lost and obliterated due to the duct obstruction. So again, mostly intraductal papillary neoplasia with high-grade dysplasia, and at least focally here, evidence of invasive adenocarcinoma. All right, well, let's move on to maybe a more benign lesion, and something that the radiologists are becoming better and better at detecting, because the features of this are quite striking radiographically. These often will be sharply circumscribed lesions, usually in the head to body of the pancreas. And they may have sort of a central scarred area. Again, they're cystic. They can be macrocystic or have a mixture of macro and microcystic features. And sometimes they're almost entirely microcystic. They have a very collagenous stroma, as you can see here. And when we look at the epithelium that lines these cystic spaces, it tends to be widely separated nuclei, low cuboidal pattern epithelium, and a little bit of slightly serous watery fluid in the lumen of these spaces. So I'm sure you've all recognized this as a serous neoplasm. Now this is in contrast to the serous tumors in the pancreas, serous tumors in the ovary, which have a different epithelial phenotype, but may also be CK7 positive. This tumor, while it has that similarity in name, there's really no relationship to the ovarian serous tumors that we'll describe later. Why are these tumors excised? Well, they can grow to become sufficiently large that they can become symptomatic. They can occasionally cause duct obstruction and create other problems. So that usually is what leads to excision. Or if the radiologist is not adept at recognizing them, that may also give a false need for surgery. But usually, if they're recognized radiographically, surgery will not be performed for these lesions. And so you may not see these very frequently for that reason. Here's another one illustrating the difference in sizes of these lesions that you can see. This one, a very macrocystic type of lesion. And so sometimes you may get a needle aspiration from these, and you may get very, very little in the way of cells. Here we can see that it's also produced some degree of acinar atrophy with residual neuroendocrine cell nests. And here this very bland, slightly frilly cytoplasm, round nuclei, centrally placed, very little or no atypia at all to the epithelial lining cells. So you could see that a needle aspiration of a lesion like this, you might get a variety of cells. You might get very few cells. You might get some admixed neuroendocrine cells, especially if these are somewhat hyperplastic. And you might get sort of a fibrous stroma in some areas. Now, as I indicated, part of the reason the radiologist can recognize them is because they tend to have this low vascularity fibrous stroma, sometimes almost scar-like in the middle. And that's one of the features that they use to recognize this tumor. Here is a somewhat different lesion. It's sort of two lesions in one. So we'll look here at this component first. And I think you'll recognize here that we have this dense hyaline fibrous stroma, very low cuboidal type epithelium. Again, you see very bland cells. They look serous. The luminal secretion is very watery, pale, proteinaceous fluid. These lesions would not have elevated amylase in this fluid, would be very bland. But then we also have, let's see here, we have some neuroendocrine cells here. These look like benign atrophic ones from atrophic acini. And then we have this over here. Well, this looks quite different, doesn't it? It's nested, solid, and has a moderate amount of intervening stroma and a few ductal elements here as well, remaining perhaps, maybe, or vessels, I guess, remaining here. As we look at these cells, we see that the nesting is quite prominent. There's a pale to clear cytoplasm, and a little bit of nuclear pleomorphism, maybe a few central either calcified bodies or enlarged nuclei, maybe multinucleated cells. So this doesn't look like a serous neoplasm, does it? In fact, it's not. This is a combined, this is a neuroendocrine tumor with these very clear cell features and an associated serous tumor of the ovary, serous cystadenoma. So a combined tumor, obviously this would look different on the radiology, and it's what led to resection. We would classify this as a combined tumor. It's not a common occurrence, illustrates that when you see an atypical feature in an otherwise typical serous tumor, serous cystadenoma of the ovary, of the pancreas, it could be something like this. Now, we have seen a few other clear cell neuroendocrine tumors in the pancreaticobiliary tree, including one in the distal bile ducts that was quite confusing for various other things as well. So somewhat of an unusual case of a combined collision tumor, I guess you'd call it. Here's one last example of the serous neoplasms. As you see here, again, another mixed macro and micro, with this one with a little bit more epithelial proliferation, maybe a little bit more complexity to the tumor. But I think you can see again here, very bland cells, very central nuclei. However, in a case like this, I think we would need to start considering other possibilities like metastatic tumors, particularly because one of the tumors that can be metastatic to the pancreas is clear cell carcinoma of the kidney. And so a tumor that has abundant clear cells and maybe starts to have higher grade nuclei, you might ask the question, is there a renal mass? Has this patient had a history of a nephrectomy or something of that sort? Because, if I didn't tell you this was from the pancreas, you might look at this and say, well, this looks like a Furman grade 1 clear cell carcinoma of the kidney. And that could be a very valid answer if you were taking your board exams in this sort of a situation. If you have a question, of course, the morphology as well as the immunohistochemistry will be different for those tumors and warrants investigation, particularly if it's a little bit more cellular and a little bit more atypical, as in this case here. Okay, I want to touch on one other mucinous tumor, and this is an unusual case that I think I have a couple of slides from this case that again occurred in the biliary tree in the hilum of the liver. And this was a patient who was receiving a transplant due to end-stage cirrhosis. So we have here the end-stage liver disease, but in the hilum of the liver in the biliary tree, we notice this somewhat unusual proliferation. Now, if this sort of looks like a fibroadenoma of the breast, I mean, that would be a good analogy. You have a stromal component as well as an epithelial component. And that's the first clue. A tumor that has a stromal component that is cellular, as well as this mucinous type epithelium, should raise consideration of the so-called mucinous cystic neoplasm of the pancreas or biliary tree. Because this is a tumor that has a characteristic stroma in addition to the epithelial component. Now, it may not be present everywhere. As you can see outside here, it doesn't have that, but the tumor inside the cyst has a lot of this type of tissue. And this is virtually identical to what you would see in the ovary. Notice here we may have occasional goblet cells. We mentioned the differing phenotypes. Here's another one over here that you can see. And again, the same circumstances of dysplasia apply to this tumor. It has a slightly different, presentation and phenotype, but in the sense of not being, kind of multiple, or main duct or branch duct kind of thing. But the epithelial features, the dysplasia scenario, all can be very, very similar to the IPMN processes. Let's look at another example. I think this is from the same area. And here the stroma is maybe a little bit less obviously ovarian. But I think you can see that there is this element of slightly increased stromal cellularity here. It's not the collagenous type of stroma that we saw earlier in the IPMN. Just a little bit more cellularity to it here. Now, occasionally in these lesions, you can actually get corpora albicantia like hyaline scarring. So little serpiginous hyaline scars that resemble the corpora albicans of the ovary. And that also is a good marker. This tumor is most frequent in women, but it can be seen in men as well. So how men get ovarian-like stroma is truly an enigma. If you have questions, immunohistochemistry can be useful. So here is an immunohistochemical stain for, I believe, progesterone receptor. And you can see that these stromal cells are nicely positive. So that's good evidence that you're dealing here with not a normal pancreatic type stroma, that you have this progesterone receptor positive stroma. And if you wanted to do an additional stain, this is an inhibin stain, again, showing not epithelial positivity, but nice positivity in many of the stromal cells. So again, another marker of ovarian type stroma. Now, I want to just mention, and I'll put maybe an image or two in the comments, that one of the tools that I have found useful in evaluating pancreatic neoplasms is a free app that is available for use on your phone or your tablet, produced by the Johns Hopkins pathology department, which sees a tremendous number of pancreatic neoplasms. And that app has a very useful teaching algorithm that helps you to walk through your thought processes. So for example, oh, is this a mucinous epithelium? Well, that's the first step. What is the stroma like? Oh, well, if it's this type of stroma, then we go to IPMN. If it's ovarian type stroma, we go to mucinous cystic neoplasm. Those sorts of sort of algorithmic approaches are very nicely outlined in that. But in addition, it has an extraordinary number of very nice illustrations, a nice atlas, if you will, of things, as well as a number of diagrams to illustrate the teaching points. So I would encourage you, if you have a tablet or something of that sort, or you're going to see very many pancreatic tumors, to consider looking at that for that lesion, or for that app, and downloading it. I get no paid endorsement here. As I said, it's a free app. It's very useful, and something that I find very useful myself. So sometimes neuroendocrine tumors can appear in the cystic cavity category. Here's one which, as you can see, has a small bowel along the surface, but was arising and eroding into the small bowel. And it's a solid blue tumor, clearly recognized as a high-grade carcinoma, a lot of necrosis, mitotic activity in this lesion, and it has neuroendocrine features, so it's a neuroendocrine carcinoma. But occasionally these tumors, these solid tumors, can also become cystic or ulcerated. And here you can see some of the residual pancreatic ductal epithelium or biliary ductal epithelium that would be associated with that. We've got time for a couple more cases. So here's another example of a neuroendocrine tumor in the pancreas. And I put this one in especially for you, Dr. Mary, because you'd asked me about insulinomas. And this particular case illustrates one of the features that can be suggestive of insulinoma. So it's clearly, it's a nested, intertwining tumor of kind of small cells, eccentric nuclei, granular cytoplasm, but it has this characteristic, very collagenous, amyloid-like or true amyloid type of deposition that is more frequently seen in insulinoma. So even in the absence of specific immunohistochemical staining for insulin, you could be suspicious or say it could be consistent with that in the proper clinical context. So I thought that was just a nice feature to illustrate in this. This was not a cystic neoplasm in the pancreas, but you can see this very extensive eosinophilic debris. And if you are able to do a Congo red stain, very often you'll be able to identify the polarizable birefringence of the congophilic material here, indicating that you have the the beta pleated sheet protein deposition of amyloid. Here's another neuroendocrine tumor. Less nested and so forth, but a little bit more single cells and so forth. We grade these using the WHO criteria based on mitotic rate and or Ki67 index. Those values are in the WHO book. I won't go into them here, but do require a fair degree of consistency and maybe some double checking to verify. Obviously, we can get cytologic atypia in these lesions without any specific implication of malignancy or metastatic potential. But unfortunately, we're still not really very good at predicting which of these neuroendocrine tumors are going to metastasize. The grade 2 ones probably are a little bit more risky, but not all of them do. And so it's again, very difficult. High mitotic rates over 20 or so, 10 or 20, those certainly are more likely to do so. Here's another tumor, again, a blue cell tumor. We can see areas of necrosis, and these can have areas of cystic change. And I'm showing these primarily to give you an idea of the spectrum that you can see in various neuroendocrine tumors. Here we see sort of a pseudoglandular pattern in some areas, a little bit of dyscohesiveness, stromal desmoplasia, but a little more hyperchromatic nuclei, a little more basophilia or amphiphilia of the cytoplasm. So again, it can look quite variable and quite distinctive in terms of the findings that you may see in these neuroendocrine neoplasms. I've given you the link to these slides if you want to come back and look at them more closely afterwards. You can certainly do that. Finally, a couple of other lesions that we need to consider in the cystic category, particularly in the tail of the pancreas. Lymphoepithelial cysts can be a presentation and can present in that location. And these will have a combination of a squamous epithelial lining, which you can see here, with accompanying lymphoid inflammation or lymphoid infiltrate in the stroma surrounding. So how you get these in the tail of the pancreas is kind of an interesting embryologic and oncologic problem, but they can have very clean keratin, or they can have an inflamed mixed pattern if they've ruptured and gotten a little bit of other tissue involvement there. And you can see the amount of lymphoid inflammation can be variable from just a small amount in some areas to quite prominent lymphoid follicles. Here's some adjacent benign lymphoid tissue where you see these lipid granulomata, lipogranulomata, clusters of histiocytes with abundant vacuoles in the cytoplasm that may be indicative of upper tract, more typical of the gallbladder area, but can be associated with cholesterol being extruded into the lymphatic stream as well. These are uniformly benign, but occasionally you may get a squamous carcinoma that might develop out of this sort of lesion. Here you can see some of the pancreatic tissue adjacent to this lesion as well, confirming its origin from that site. Well, I wanted to get to one last tumor type because this is a tumor that can be occasionally confused with neuroendocrine tumors because it has this very uniform round cell appearance. But in contrast to neuroendocrine tumors, while this tumor is occasionally positive with synaptophysin, it's also positive with beta-catenin and occasionally with CD10. It also tends to present in the body of the pancreas rather than the tail, and it tends to present in younger patients. So this is the solid pseudopapillary tumor. As you can see, that kind of is an interesting name, but the pseudopapillae is based on these type of structures where you have a little bit of a central vessel and then surrounding epithelial-like cells that tend to fall apart, forming a sort of pseudopapillae. So that's why these can occasionally become cystic, because this degenerative cystification change becomes so prominent here that it looks like it's forming a cyst. And here you get almost a follicle-like structure over here, as you see. And these tumors also tend to get areas of infarction or hemorrhage. They can get a lot of cholesterol clefting. But this pattern of these sort of cleft-like spaces and these pseudopapillae is pretty classic for this solid pseudopapillary tumor. Notice that the nuclei are fairly round and uniform. They're very low grade. This is pretty much a benign or minimally locally invasive tumor. It does need to be resected because it can progress and cause problems. But the prognosis with a good resection is uniformly favorable if you've got good margins and so forth. So we're at 8 o'clock. I think I'll show you one more example of this solid pseudopapillary tumor just to illustrate a little bit of the differential here. So here we see pancreas. Here's some normal acinar structures, ducts, and so forth. And in this tumor, we have some sort of clear cell change happening as well. But notice that these sort of lipidized cells, again, they have quite uniform rounded nuclei. So I think these are truly the solid pseudopapillary cells because they were beta-catenin positive. But notice this extensive degenerative change that we have here. A lot of cystic change, cholesterol clefts, and so forth. And then down here, we see, again, this same pattern that we saw earlier, this pseudopapillae. And even though it's kind of infarcted, you can still see kind of the ghost-like pattern of this tumor. So I don't know the specifics of staining on this case, but I believe this is certainly solid pseudopapillary tumor. And I believe that this other change that we're seeing here in the wall of this is probably related to that in some manner. Okay, so we're at the top of the hour. We've got a couple of questions here from Dr. Mary. Do we do cytology for the pancreatic specimen by endoscopic ultrasound? So yes, we do these rapid on-site evaluations. And we will usually do a GIMSA-like stain, a diff-quick stain, or a methylene blue stain to evaluate these tumors at the cytology bench. Now, sometimes if they're pretty assured that it's a carcinoma, our surgeons have begun to do endoscopic needle core biopsies because they like to have formalin-fixed tissue for next-gen sequencing or other sorts of things. So if they can give us a fair number of those, we may not need to do a rapid on-site. But I still think that rapid on-site assessment is quite useful in minimizing the duration of the procedure and assuring that you've got a good sample. So very good question. Any other questions or thoughts? Appreciate everyone being with me this morning. It's been a lot of fun. I enjoy talking about the pancreas, as you can tell, even though I occasionally slipped into the ovary. And if you have follow-up questions, please don't hesitate to send those to me. I'll post the video from this session today later on today, so it'll be available over the weekend. And again, thank you everyone for joining me. And we will do it again next month in July. We'll be back onto the third Friday, do it on the 15th of July for our next session next time. So unless you have any other questions, have a great day. Thank you for joining me.
Thank you, Dr. Estel.
It's a pleasure.
Thank you very much. Have a nice day. Thank you.
All right.
Thank you so much.